Rahmatullah. The second lecture of hepatobiliary system, we discuss the major manifestation of hepatobiliary disease. The common symptom that complain the patient to our clinic. We discussed the major manifestation of this symptom of this disease. The major symptom jaundice. What mean by jaundice? The jaundice, or called icterus, is yellowish discoloration of the skin or mucous membrane resulting from the deposition of the bilirubin due to hyperbilirubinemia. The total serum bilirubin is normally 0.2 to 1.2 milligram per deciliter, and the jaundice may be not be recognized until the level are about more than 3 milligram per deciliter. So the jaundice not appear until the level of the serum bilirubin in the blood more than 3 milligram per deciliter. So the level between the 3 milligram or to 1.2, the level between 1.2 to 3 milligram called subclinical hyperbilirubinemia. That means there is an increase of serum bilirubin in the serum, but without evident clinically as a jaundice. Subclinical hyperbilirubinemia, when serum bilirubin increase more than normal level, that means between the 1.2 to 3 milligram per deciliter, with undetectable jaundice clinically. So the jaundice is commonly present in our clinic and can be classified according to the site, according to the disease, according to the pathology. So firstly, we discuss the metabolism, our protection on metabolism of bilirubin. The bilirubin is the end product of heme degradation, result from destruction of the heme that enter in the composition of the hemoglobin and other cytochrome enzyme. About 70 to 90% of the bilirubin is derived from the degradation of the sensate RBC, and the remainder from the hemoprotein such as myoglobin and cytochrome enzyme. The major part of the bilirubin come from the sensate, يعني العاجزة أو الكبيرة, RBC destruction. The half-life of the RBC about 120 days, so then destructed. The end product of destruction of RBC lead to destruction of the hemoglobin. The heme degradation lead to bilirubin. So 70 to 90% of the bilirubin come from RBC, but can come from other sites that protein contain heme. Example, myoglobin and cytochrome enzyme. We have two types of bilirubin, conjugated and unconjugated bilirubin. Unconjugated bilirubin is water insoluble, so it is not pass in urine. It should be bound to the albumin. It's bound to the albumin and does not pass to the urine. It is transported to the liver by carrier-mediated kinetic that enter to the hepatocyte. The bilirubin in the hepatocyte is conjugated with 1 or 2 glucouronic acid by enzyme called the glucuronidase transferase enzyme to form both mono and diglucuronide, respectively. This conjugated bilirubin, after the conjugated in the hepatocyte, are water soluble and can be exported to the biliary system, then to the intestine by specific carrier in the membrane of hepatocyte. So the water soluble conjugated bilirubin can pass in the urine and appear in the stool also. The conjugated bilirubin is then, when reached to the intestine, metabolized by the colonic bacteria to form a substance called stercobilinogen, which may be further oxidized to stercobilin. Both stercobilinogen and stercobilin are excreted in the stool. So, the presence of the stercobilinogen and stercobilin in the stool lead to normal color of stool. When the absence of this substance from stool lead to gray and clear stool, colorless stool. A small amount of stercobilinogen from the bowel reabsorbed, about 4 milligrams per deciliter, is absorbed from the bowel and pass returned to the circulation and then to the liver, then excreted in the urine, lead to known as urobilinogen, and further oxidize when appear in the air, lead to formation urobilin. The urobilinogen and urobilin lead to normal color of urine. This diagram reveals the process of the metabolism of bilirubin inside the intravascular or extravascular hemolysis of the RBC result from the unconjugated bilirubin. Then conjugated bilirubin are bounded to the albumin, then enter the hepatocyte by specific kinetic. Inside the hepatocyte, there is a conjugation to the mono and dichloroglucuronide. The lead to formation of the conjugated bilirubin. The conjugated bilirubin then is secreted in the biliary system. And the biliary system then pass to the intestine, inside the small intestine, and then to the large bowel. In the large bowel, there is a bacteria, lead to metabolism by this bacteria. The bacterial protease enzyme to formation of the stercobilinogen. The stercobilinogen is small, 10% about stercobilinogen reabsorbed to the portal, then to the circulation, and remetabolized by the liver, then excreted by the kidney, lead to urobilinogen and urobilin. About 90% of stercobilinogen then pass to the stool, lead to formation stercobilin, lead to the normal color of stool. This summary of the metabolism of the bilirubin. How to approach to the patient with jaundice? When you're facing in our clinic, the patient complains from jaundice. واللي عرفناه هو yellowish discoloration of skin and mucous membrane, of the palm, of the skin, of the eyes commonly appear in the eye. We ask about the following. The duration of the jaundice are very important, whether it's acute or chronic. In the chronic, there is a chronic liver disease, a chronic hemolysis, and a chronic obstruction of the biliary system. When the acute, within days or within hours, that means acute hepatitis, drug ingestion, toxicity, lead to acute jaundice. So the duration are very important to the differentiation, the different causes of the jaundice. Use or exposure to the medication or outcome to medication or any physician prescribed that drug toxicity lead to acute hepatitis and present with jaundice. Or complementary or alternative medicine like herbal or vitamin preparation or steroid, all these lead to liver damage and lead to jaundice. Or any expert or blood product transfusion or IV abuse lead to jaundice. Ask about tattoo or sexual sudden loss of appetite or loss of weight, that means it is malignancy or chronic liver disease. Diabetes. Diabetes, that means the severe liver injury or obstructive liver disease lead to vitamin K deficit and a bleeding tendency. All these should be asked in the history when facing patients with jaundice. Recent trouble exposure to the endemic area, exposure to the patient with jaundice, if there is any jaundice patient in the family. So when the facing patient with jaundice ask about the family, if there is a familial disease, either infectious disease like hepatitis, or due to the inherited disease, example, the thalassemia or sickle cell anemia lead to hemolytic anemia and jaundice. Occupational history contact with rat. That rat transferred the spirochete, lead to spirochete disease, lead to hemolysis and jaundice. Exposure to contaminated food and water. Also ask about if there is any exposure to the dirty water and dirty food that lead to toxicity and poisoning or lead to transmitted of the infectious disease. Family history of hemolytic anemia. Also, if there is hemolysis, history of the congenital hyperbilirubinemia, inherited disease, example, thalassemia and sickle cell anemia. Also, inherited hepatitis, all these should ask about. Dyspepsia of food intolerance, if there is a biliary colic, that means the gallstone or biliary disease, as or any surgical disease lead to dyspepsia. Any accompanying symptom, if the jaundice associated with arthralgia, skin rash, anorexia, weight loss, abdominal pain, that means a symptom of the ascending cholangitis. Symptom of ascending cholangitis characterized by fever, pruritus, and abdominal pain. That means the patient had the cholangitis. The cholangitis is an inflammation of the biliary system due to prolonged obstruction of the biliary. All these should be asked in the history to reach to the final differential diagnosis and then to the final diagnosis. After complete history, the examination, we assessment of the nutritional status of the patient. We look to the temporal and proximal muscle wasting. If the patient wasting, loss of weight, muscle wasted, that means the debilitating disease, chronic liver disease, liver cirrhosis, CA of the liver, all these lead to the muscle wasting. Scratch mark, pruritus, fetal hepaticus, scratch mark, any mark due to the itching, or purpura, that means bleeding tendency in the skin. Fetal hepaticus, that means bad smell from the mouth result from the advanced liver cirrhosis. Stigmata of chronic liver disease, like spider nevi, Palmer erythema, gynecomastia, Cabot modosa, diphtheria contracture, parotid enlargement, testicular atrophy, all these in advanced liver cirrhosis. اللي نسميها stigmata of liver disease, stigmata of liver cirrhosis, in the face, in the palm, in the leg edema, all these should look for in the examination. After general examination, abdominal examination. In abdominal examination, we look for the size of the liver, consistency of liver and spleen, if there is hepatomegaly, splenomegaly, if nodular liver, that means the malignancy. Hepatic congestion, if there is liver is congested and tender, that means the alcoholic or viral or parasitic or amyloid deposit. Nerve sign here, tender site below the liver, that means the palpable gallbladder, Coverser sign, that indicated the carcinoma of the pancreas lead to enlargement of gallbladder and palpable by the palpation. Also examine for ascites and jaundice, that mean complication from liver cirrhosis or from the malignancy. Abdominal vein, also look for if there is abdominal vein enlargement, indicate the advanced liver cirrhosis. So by examination, we start by systemic examination for the face, hand, and leg, then specific examination for the abdomen to look for all these signs. The type of jaundice. The jaundice can be classified according to the site of the disease. So jaundice divided into 3 categories based on where they start before, in, or after the liver. Before the liver, called prehepatic jaundice. Inside the liver, called hepatic jaundice. Beyond the liver, called post-hepatic jaundice. The prehepatic, or called hemolytic jaundice, result from increase of production of bilirubin. This result from destruction of RBC, excessive destruction of RBC, example, hemolytic anemia, thalassemia, sickle cell anemia, infection of the RBC, result from excessive destruction of the RBC, lead to more production of bilirubin, more than beyond or more than the capacity of liver to clearance of this bilirubin. بمعنى انه البيليروبين accumulated in the serum more than the capacity that cleared by the liver, lead to increase the bilirubin in the serum and evident as jaundice. The causes of the jaundice caused by anything which cause increased rate of the hemolysis or breakdown of RBC. In the tropical country, malaria can cause jaundice in this manner. Certain genetic disease, اللي هي common disease in our society, sickle cell anemia, thalassemia, glucose, G6B deficiency can lead to increase the RBC lysis and therefore hemolytic jaundice. Ineffective erythropoiesis in the bone marrow also lead to early destruction of RBC inside the bone marrow and lead to jaundice. What's the clinical feature of the prehepatic jaundice? There are often no stigmata of chronic liver disease other than jaundice. Normal, so that means there is no stigmata of liver disease. The liver is normal. Liver enzyme all are normal because their disease before the liver due to inside the blood, not in the liver. So the liver enzyme are normal. Second, normal color or dark stool due to circobilinology. Dark color urine in standing due to urobilinology. So both the stool and urine are deep in color due to unconjugated bilirubin. Sign and symptom of hemolytic disorder. Sign and symptom of the hemolytic anemia, thalassemia, sickle cell anemia. Example, Bala due to anemia, splenomegaly due to thalassemia or sickle cell anemia, or spherocytosis. All these look for. هذا اللي راح نشوفه in patient with prehepatic jaundice or called hemolytic jaundice. Investigation increase only unconjugated bilirubin and usually mild, elevated, less than 6 mg per deciliter. The normal liver function because the intact liver. The blood film revealed the hemolytic anemia, sickle cell anemia, thalassemia, spherocytosis in the blood. Other type of the jaundice called hepatocellular jaundice. The hepatocellular jaundice, any disease inside the liver, whether acute liver disease or chronic liver disease, lead to destruction of hepatocyte. So destruction of hepatocyte result from regurgitation of both conjugated and unconjugated bilirubin to the bile duct. So destruction of hepatocyte lead to regurgitation or discharge of the conjugated and unconjugated bilirubin inside the biliary duct. The causes, any causes, first acute parenchymal liver disease. Example, viral hepatitis, hepatitis A, B, C, and so on. Alcoholic hepatitis, drug-induced hepatitis, Wilson disease, and autoimmune hepatitis. All these lead to acute liver parenchymal disease or chronic parenchymal liver disease. Example, chronic viral hepatitis, alcoholic hepatitis, autoimmune hepatitis. All these lead to the most common cause of jaundice اللي هي hepatocellular jaundice. Sorry. The clinical feature of the hepatocellular jaundice, the clinical feature of hepatocellular jaundice depend on the underlying disease. Example, Wilson disease, hepatitis, hepatitis B, according to the cause. Usually, the patient have general feature of the hepatitis like nausea, vomiting, abdominal pain, arthralgia, and dark color of both urine and stool. So when the patient with abdominal pain and fever and upper abdominal pain, when examine the abdomen, there is a tenderness in the upper abdomen with yellow discoloration of sclera with dark color urine. We put the high suspicion of the hepatitis or any parenchymal liver disease. So the clinical feature of the patient with hepatocellular jaundice depend on the cause. So example, when the cause is due to the alcoholic, there's history of alcoholic intake on the patient with the other sign of the alcoholism. Plethoric phase, parotid enlargement, and associated with jaundice. Other example, for example, Wilson disease. If there's Wilson disease, there is a KF ring in the eye, associated with jaundice in the young age patient. So we put that the cause due to Wilson disease. So the clinical feature of the patient with hepatocellular jaundice depend on the cause. Once in the patient for investigation, in the blood, there's both conjugated and unconjugated hyperbilirubin. So in the blood, the bilirubin increase both part, conjugated and unconjugated, because the regurgitation of both conjugated and unconjugated in the blood. Second, the increase ALT and AST enzyme more than alkaline phosphatase. هذه liver enzyme very important. هاي النقطة مهمة. In the hepatocellular jaundice, there is an increase ALT and AST more level than alkaline phosphatase. عكس obstructive jaundice. Obstructive jaundice, alkaline phosphatase more than the other enzyme ALT and AST. Another last part, third type of the jaundice called post-hepatic or cholestatic jaundice. The post-hepatic or cholestatic jaundice results from impaired excretion of bilirubin to the intestine through the biliary system. There is due to obstruction of the passage of the bilirubin, either intrahepatic or extrahepatic obstruction. Any disease lead to obstruction of the biliary system called obstructive jaundice or cholestatic jaundice, or سميه post-hepatic jaundice. It causes the pathology is located after the conjugation of the bilirubin in the liver. That means the conjugation is intact, but the disease after the conjugation lead to increased conjugated bilirubin. It's caused by interruption to the passage of the bile in the biliary system, either intrahepatic cause inside the liver or extrahepatic due to cause outside the liver. Intrahepatic cause of the jaundice. Example, a primary biliary cirrhosis. A primary biliary cirrhosis. This autoimmune disease resulting from an inflammation of the biliary passage, commonly in the young ladies, lead to chronic inflammation on yield with cirrhosis. Other primary sclerosing cholangitis, liver disease, also alcoholic liver disease. طبعا alcoholic give different type of the jaundice, either hepatic, prehepatic, and post-hepatic. So alcoholic liver disease can be caused obstructive jaundice. A drug that lead to obstruction, example, oral contraceptive pills, anabolic steroid. cholestasis of viral hepatitis. Any viral hepatitis, example, hepatitis A. So start by hepatocellular jaundice, but with the clearance at the end stage of the disease lead to cholestasis, called cholestasis of viral hepatitis. Cholestasis of pregnancy, or both of cholestasis. At the end of the pregnancy, there is obstructive jaundice, and some ladies lead to obstructive jaundice, or patients with massive surgery also may be complicated by cholestasis. This intrahepatic inside the liver, but outside the liver, most commonly surgical causes. Example, gallbladder disease, gallstone, common bile duct stone, any stone that obstruct the biliary passage lead to obstructive jaundice. CA of pancreas, CA of umbella of Vata, a traumatic biliary obstruction or tumor, like surgical trauma to the biliary passage, or tumor of the umbella of Vata, or tumor of pancreas. All these malignancy may be lead to obstruction of biliary passage. What's the clinical feature of the obstructive jaundice? The clinical feature of cholestatic jaundice or obstructive jaundice include these due to cholestasis itself or due to the cholangitis. Either due to cholestasis due to obstruction per se, or due to an inflammation of the biliary system called cholangitis. So first, the feature of cholestasis. Feature of cholestasis divided according to the time, either early feature or late feature. An early feature, in acute stage, the obstruction lead to deposition of the jaundice yellowish to greenish color of the eye, lead to yellow to green. يعني differ from the other part of jaundice. لما نطوع السكليرا نشوفها yellow to green color. So when look to the patient, the spot diagnosis can be diagnosed obstructive jaundice from the color, yellow to the green of the sclera, mostly result from the conjugated bilirubin. The conjugated bilirubin in the sclera lead to yellow to greenish color of the eye. Dark urine due to hyperbilirubinemia. Okay, because the conjugated bilirubin is water soluble, so mostly pass in the urine lead to deep color or cola color urine. Pale stool, the stool is colorless. That means pale stool or clay color stool due to absence of the stercobilinogen. There is no stercobilinogen pass in the stool due to obstruction of biliary system lead to pale stool. Second, pruritus due to deposition of the bile salt in the skin. So the retention of the bile salt because of obstruction lead to pruritus due to the lead to irritation of the end of the nerve lead to pruritus. So there is yellowish to greenish color of the sclera. There is color or deep color urine, pale stool, and pruritus due to bile salt in the skin. This early feature. The late feature of the lipid soluble vitamin. Example, deficiency of the vitamin D, E, A, K. This result from the following: xanthelasma and xanthoma due to hypercholesterolemia. Why the hypercholesterolemia occur? Because an increased level of cholesterol in the serum result from reduction in the turnover of the cholesterol due to retention of the bile salt. واحنا نعرف انه البile salt synthesis from cholesterol when the obstruction or stop the synthesis of the bile salt lead to retention of cholesterol in the blood and lead to deposition in the eye called xanthelasma, in the arm or in the skin called xanthoma. Malabsorption feature, example, weight loss, steatorrhea, osteomalacia, and due to deficiency of lipid-soluble vitamin. So vitamin D deficit, because there is any lipid-soluble vitamin, decrease. Why decrease decrease in these vitamins? Because the bile salts are very important to the absorption of the fat. Because these vitamins are fat soluble, so lead to deficiency. Vitamin D deficiency lead to osteoporosis, osteomalacia. Vitamin E lead to bleeding tendency. Vitamin A lead to blindness. Vitamin K lead to bleeding, and so on. So this is called late feature of the obstruction. Or feature due to cholangitis. Any obstruction for long time of biliary system complicated by infection. Sign of infection, the patient come to you with fever, abdominal pain, rigor in semi-charcoal trial. Fever, abdominal pain, and rigor with jaundice. That means the feature of cholangitis. May be complicated with hepatic abscess. The investigation of the patient with obstructive jaundice, there is mainly increased conjugated part of bilirubin. لما نسوي blood test, the bilirubin mostly conjugated. Second, increased alkaline phosphatase and gamma-glutamine transferase enzyme more than ALT and AST. عكس الهيباتوسيلولار، ان الهيباتوسيلولار الاي ال تي والاي اس تي مور ذان الكلاين فوسفاتيز. هنا بالأوبستراكتيف جونديس الالكلاين فوسفاتيز مور ذان اي ال تي and AST. Ultrasound examination reveal the intra and extra biliary duct dilatation or may be found the cause of obstruction. Example, common bile duct stone, gallstone, detecting of the head of pancreas mass due to malignancy, ampulla of water malignancy, all can be detected by ultrasound. But commonly ultrasound reveal the intra and extra hepatic biliary dilatation. That means there is an obstruction. Another subject called isolated hyperbilirubin. Only there is only increased bilirubin without other symptoms. With normal liver enzyme, increased bilirubin is called isolated hyperbilirubinemia. Increase liver أو العفو serum bilirubin with normal liver enzyme cause either unconjugated inherited disease, example Gilbert syndrome or Krieger-Najjar syndrome. This is inherited disease due to enzyme deficit, lead to unconjugated hyperbilirubinemia. Increase unconjugated bilirubin with normal liver enzyme. The other called conjugated. Example inherited disease here, Dobbin-Johnson syndrome and Rotor disease lead to conjugated hyperbilirubinemia. From all talk above can be summarized in this table. This table, the differentiation between hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice regarding the basic defect and elevation of serum bilirubin, mild, and the hemolytic jaundice, severe in both hepatocellular and obstructive jaundice. The plasma, mainly conjugated in the hemolytic jaundice, and unconjugated in hemolytic jaundice, while conjugated in the both obstructive and hepatocellular jaundice. Bile in the urine, absent in the hemolytic jaundice, but present in the hepatocellular and obstructive jaundice. Regarding all these كل هذا الكلام اللي حكيناه بالمحاضرة، فهذا مختصر للمحاضرة اللي هو يفرق لك between the different type of the hemolytic different type of jaundice. This picture reveals xanthelasma. Xanthelasma اللي هي deposition of the cholesterol around the eyes due to hypercholesterolemia is a feature of obstructive jaundice. This eye reveal yellow to yellow to green color of the sclera due to mainly conjugated hyperbilirubinemia indicate the obstructive jaundice. Obstructive jaundice. This deposit of the cholesterol in the skin, in the forearm, that means xanthoma. Xanthoma, deposition of the cholesterol in the skin due to hypercholesterolemia, the sign of the obstructive, chronic obstructive jaundice. هي نسميها late feature of the jaundice. Thank you. شكرا جزيلا.